Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. My name is Dr. Jeanine Cook-Garard from the Nursing Department here at Nassau Community College. Today we're going to talk about your heart and how to keep it healthy. Heart attacks do not discriminate. Women are just as likely to have a heart attack as men, but studies show that women are more likely than men to die from one. To learn more, please welcome my guest today, Dr. Evelina Grayver, the Director of Women's Heart Health at the Katz Institute for Women at Northwell Health. She is also an assistant professor in the Department of Cardiology at the Donald and Barbara Zucker School of Medicine at Hofstra, Northwell. Dr. Grayver, welcome to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. Welcome.
Thank you so much. It is such a pleasure and honor to be here with you guys.
So tell us first about you. Why did you decide to become a doctor that specializes in cardiac care?
I always knew that I was going to be a doctor. I'm originally actually from Ukraine, but when I was born in Ukraine, it was still the former USSR. I always refer to myself as being Russian because we were all Russian back in USSR. So when I was born back in former USSR, there are actually pictures of me from the Russian daycare playing doctor. I actually remember being about 5 years old and setting up a row of all of my friends with every single one of their toys. And I clearly remember myself saying, "You let me know what's wrong with them and I will fix it."
Aww.
So I always kind of knew, I know it's oddly weird and cute, I guess, but I always knew the fact that I was going to be a doctor. Why? I don't know. I don't have any physicians in my family. My family all of the women in my family are all incredibly creative. They're all musicians and pianists, and all of the men on the family are, math and science guys, engineer. So there are no physicians in the family. So I don't know why that idea ever came to me. And then in reference to cardiac care, I remember I was about 16 years old, and now this is already now here in the U.S. We immigrated when I was about 10 years old. My father and I would run together all the time. He used to train me. I was on the varsity track team in high school, and he would train me. He would run with me. And there were certain days that he would start running with me and that he would have to stop and say, "You know what? Getting old really, really sucks," because I would start running and get some chest discomfort, and then he would have to stop. And then in 5 minutes, he could resume the run with me. And back then, I kind of knew the fact that didn't seem right to me. And lo and behold, my father at the age of 48 had his first cardiac event that landed him in the emergency room and subsequently with 6 cardiac stents.
Wow. And
then the rest is history, as they say.
So tell me the difference in heart disease with women versus men.
So the difference is that, we all have a heart, right? And our hearts are quote unquote similarly, right? Our hearts have the same type of coronary supply, which is the plumbing, which is where the blood supplies. And we all have the same electrical supply, right? And that's what actually keeps the heart beating. The issue is the fact that our vessels in women are different on a very, very tiny pathological level, where that's why the blockages in men usually happen within some of the main arteries, and the blockages for women happen in more of the minor vessels. And that's one of the reasons why the presentation at times is very, very different. So, Hollywood has done a phenomenal job that where when a man clutches his chest, we all know the fact that that man is having a heart attack. When a woman clutches her chest, for whatever reason, we assume the fact that she's either having an anxiety or panic attack, or it's some sort of a gastrointestinal component. So the presentation for women with heart disease is incredibly different. It's not usually chest pain or chest tightness. They very rarely describe an elephant sitting on their chest. But what they do have is significant shortness of breath and significant fatigue that subsequently is sort of their source of cardiac disease.
So with a woman having very different symptoms than men, if they're coming into the emergency room, how are you able to readily tell whether that person is having a cardiac event or just a stomach illness or just an anxiety attack?
So let's begin with the woman coming in with her symptoms, her atypical symptoms, as we like to say, right? And this is where a woman is met with multiple biases, even from my own colleagues, even within healthcare. And within triage, right, there's tremendous amount of data to show that even women that actually do present to the emergency room, there's approximately 20% longer wait time for them than for men that actually seek medical help. And that's part of the bias. But the way to sort of distinguish whether or not it's a panic attack or whether or not it's potentially a GI component, the first thing that has to be done is an EKG, an electrocardiogram. But what I teach my patients and what I teach my residents and what I teach my fellows is the fact that an EKG gives you very minimal bird's eye view into what's happening with the cardiac component, because it's only useful when you have the stickers on the patient or when the patient is actually doing something upon exertion. When a woman or a man, actually for that matter, comes in and has an EKG and quote unquote, it looks normal, right? It does not mean the fact that they don't have any underlying coronary disease. It just means the fact that at the time, while the stickers were on the patient and while the EKG was being run, they were not having an active cardiac event. That's all it means. EKGs have zero to no prognostic features. I tell that to my patients all the time that, just because an EKG looks normal, I can't tell you what could happen to your heart 5 minutes after you walk out of my office, really.
So what is the diagnostic test that would really definitively tell you that that woman is having a cardiovascular event?
I want to step back for a second. I am not a big believer in cookie cutter approach to medicine or cookie cutter approach to patients at all. So I think that it's a very individual component, right? So it all depends upon the patient's risk factors, right? Personal risk factors and family history. And then based upon that, it is very important then to choose the most specific test for that patient. So the most common test that anyone that would come to see me that I would start off with would be an echocardiogram, which is a sonogram of the heart, and an exercise stress test, right? So an echocardiogram, which is a sonogram of the heart, will tell me as to what the heart is doing, how well is it beating, and is there any underlying disease of their valves that could also be contributing to cardiovascular disease. And then subsequently, I would do the stress test. And a stress test is when you kind of feel like you're in, Rocky 3 when he's walking up and training, right? Is when a patient goes on the treadmill and every 3 minutes, the treadmill gets a little faster and a little higher. And during that period of time, the patient is connected to an ongoing EKG monitor, so we can see what happens to that EKG when the patient's heart is increasing, when the patient is upon exertion. Now, for women, and this is a huge distinction between men and women have a lot of what's called a falsely positive stress test. What does that mean? It means the fact that during the time of the stress test, there's significant amount of EKG changes. And that pushes us to actually do further testing. And this is where the most specific test comes into play for women. And that's a cardiac CT. A cardiac CT not only looks at what's called macrovascular components, which is the big vessels, but the microvasculature as well, which is a lot as to where a lot of women do have issues is within the small vessels of the heart.
So this cardiac CT, it is a scan. And tell me a little bit about what happens during a cardiac catheterization.
Cardiac CT is a non-invasive test versus a cardiac angiogram. A cardiac catheterization is an invasive test. So cardiac CT is just truly just like any type of a CAT scan. You lay down, you get an IV, and through that IV, you have contrast that is being injected. And you go into a CAT scan tube, and during which certain cycles of the heart, images are being taken, and your coronary anatomy, coronary arteries are being closely looked at. cardiac CAT scans look at what's called a calcium score. Calcium score is how much calcification is already embedded within your coronary arteries, and the higher that calcium score is, the higher the risk of plaque or blockage formation. Usually when somebody has a calcium score of greater than 400, it's sort of a monstrous red flag for us to then further refer the patient to get a cardiac angiogram or the cardiac catheterization. Mm-hmm. So cardiac catheterization is the invasive component, right? Is where we actually put in a catheter, and the catheter is a little bit longer and wider than your typical IV. And we usually go either through the wrist, through one of the arteries in the wrist or one of the arteries in the leg. We put in that catheter, and then through that catheter, we slowly thread our wires, which allow us to look under a huge fluoroscopy tube or huge radiation tube at the coronary arteries. And we're able to see whether or not there's any significant blockages or not. So what's considered to be a significant blockage, right? A significant blockage is when there's a blockage of 70, 75% and greater. And those are the lesions that we usually then evaluate whether or not they are a candidate for a stent placement or not. So cardiac catheterization has two major parts. There's the angiogram part, and that's the diagnostic component when we actually just look at the coronary arteries. And then there's the angioplasty part, and that's the part where we actually put in stents if they are warranted at that time.
So what is the benefit of a stent? What do stents do while you're doing this cardiac catheterization? What do the stents?
So what is a stent? A stent is a metal mesh. It's a metal mesh that actually is on a small little balloon that if we do find a significant blockage in the artery, coronary artery, then we know the fact that there is a decreased blood flow through that artery. Then we know the fact that the patient is in increased risk for what's called having angina or chest pains, or potentially even having an acute coronary syndrome, which is a heart attack. Okay, so we try to prevent that by putting in a stent. And like I said, it's a metal mesh that keeps that artery open. We assess based upon the initial angiogram how significant is the blockage, how long it is, how big the vessel is, and then we subsequently approximate as to what kind of stent we need, how long, how wide, and we implant it. And it's a permanent fixture. A lot of patients always want to know whether or not it's something that gets removed afterwards or not. No, once a stent is placed to open up that artery and to keep that artery open, so there's a nice laminar flow of the blood flow to the rest of that artery, the stent stays in. It is a permanent fixture, really. And it's MRI compatible, which is another very common question that I get from a lot of my patients as to whether or not with a stent implant, can they get MRIs? And yes, stents are all MRI compatible.
So they can go to the airport and they can get the
Correct.
MRI. Okay.
Yes.
You're listening to Your Family's Health on the voice of Nassau Community College 90.3 WHPC. My name is Dr. Jeanine Cook-Garard. And today you're learning about heart health and if there are differences between men and women when it comes to taking care of your heart. My guest is Dr. Evelina Grayver, the Director of Women's Heart Health at Katz Institute for Women at Northwell Health. She is also an assistant professor in the Department of Cardiology at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. So we talked a little bit about women and their predisposition for heart disease. So what would be the potential patient that you would probably say will probably experience some heart disease?
Interestingly enough, there is really no typical patient, right? When you're seeing a patient that is walking down the street that looks like, oh my God, that is a cardiac time bomb waiting to happen. It's usually not the case, right? But I will tell you sort of the most common features that I do see in women. It's mostly a perimenopausal or postmenopausal woman.
Why so? Why is perimenopausal women more predisposed?
So it's because of the fact that we lose the protection of estrogen. Mm-hmm. Estrogen is incredibly protective to our coronary arteries. It's protective for that atherosclerosis plaque not to form. But I think it's more to the story, and this is where a lot of the research is taking place right now. I think that there's a humongous inflammatory cascade that happens within the woman's body during the time that she is perimenopausal. And that inflammatory cascade is what sometimes causes the rupture of that plaque, the rupture of those small blockages that are already forming in the arteries, and then subsequently cause a blockage of the artery. So I think that there's two things, right? It's the loss of the estrogen and the inflammation that takes place during the time of menopause that actually causes women to be a little bit more predisposed to cardiovascular disease at that period of time. But my typical woman would be age 50 to 55, who has been active her whole life and tries to stay active at this period of time. She might have a little bit of elevated sugars. She might be pre-diabetic. Her cholesterol may not be ideal, but her primary care physician told her it's okay. It's not that bad. Women are not predisposed to heart disease. You're okay. And borderline hypertension comes to me most likely. One of the most common concerns is, you know what, doctor, I'm always active, but somehow recently I'm just not able to finish my workout, right? So it doesn't jump out at you and say she's having a cardiac event, but there's a significant change, right? And she can't pinpoint it. She's not telling me she's having chest pain. She's not telling me she's having atrocious shortness of breath, but it's a combination of it all, right? It's a combination of fatigue and shortness of breath that is most likely causing her not to be able to finish her entire workout. And the most interesting part, and this is sort of one of the other, niches that I have at this point, is one of the most common features in a lot of these women that I now see is the fact that during the time when they were pregnant, they had some degree of what's called adverse pregnancy outcome, meaning they either had gestational hypertension or they had preeclampsia. And in the past, all of those events used to be thought of, like Vegas almost. What happens in Vegas stays in Vegas. So what happens in pregnancy stays in pregnancy, or resolved as soon as the woman is no longer pregnant. Well, we know now the fact that these adverse pregnancy outcomes are actually now considered to be novel gender-specific cardiovascular risk factors. So now, in addition to the sort of the typical risk factors that we know of, which is the diabetes, the high blood pressure, cholesterol, obesity, family history, smoking, all of that, now we have to be able to appropriately screen a lot of these women, whether or not at the age of 20 or 30, when they were pregnant, did they have any underlying adverse pregnancy outcomes, right? And majority of the patients, I would probably say, close to 3/4 of my patients that I now see in their mid-50s do tell me, oh yeah, when I had my baby in my 20s, I had blood pressure issues, but no one really mentioned anything. I took meds for a week or two after my pregnancy, and then I was good, right? And that's what I mean by, what happens in Vegas stays in Vegas. That was the old school mentality where those adverse pregnancy outcomes were really not thought of as something that can have long-term effects, cardiovascular effects specifically.
So what can I do to prevent cardiovascular disease? I mean, you spoke about different indicators. Is there a special range or a particular range that I have to keep my blood pressure within, or when I'm thinking about my A1C, or I'm looking about my cholesterol level, what is the range I'm looking to stay within? Tell me about some of these markers. Yeah.
100%. So let's talk about numbers. So first of all, I think that it is important for every single patient, men or women, to actually know their numbers. So let's go through all of that. So you mentioned a couple of things. So yes, for your sugars, for your diabetic markers, we look at what's called hemoglobin A1C. Hemoglobin A1C is a marker of how well your sugars have been controlled over the last 3 months. And then a normal A1C should be less than 5.6, 5.7. So that's one of the numbers that people definitely need to know. The blood pressure wise, well, the guidelines change all the time, but the most recent ones really stress on making sure the fact that your blood pressure is less than 120/80. Cholesterol, well, cholesterol is one of those things that, again, there's no really cookie cutter approach, but to be in good cardiovascular health, you really want your LDL, which is the bad cholesterol, to be less than 100. And for some people, and again, based upon your family history, based upon on other factors, LDL should be actually less than 70. Obviously, you do not want to smoke. And if you don't smoke, do not start smoking. And if you do smoke, please try to stop. One of the other numbers that is also very important that I track with my patients is their body mass index, which is really sort of what their weight is in comparison to their height. And you want your BMI, or the body mass index, to ideally be less than 25. One of the things that also maintain, in addition to knowing your numbers, obviously you want to maintain a heart healthy diet. And, we can talk for hours as to what that actually means. But the most common diet that is actually has the most evidence at this period of time is the Mediterranean diet, and we can go through that.
Right.
One of the other things is the physical activity, right? So everybody always wants to know how much should they be exercising, what kind of exercise that they should be doing, and everything else, right? So I always recommend to my patients, and this is sort of what the American Heart Association recommends, is that at least 30 minutes a day, at least 5 days out of the week, of moderate cardiovascular exercise, right? And it means anything and everything that you like. Anything from walking to spinning to elliptical machine, and even as much as dancing, as long as it could be potentially something that you enjoy wholeheartedly, and you're going to be able to do without feeling like you're being forced to do it. Because if you enjoy doing it, then you're going to continue doing it versus potentially being forced to do it. And then one of the other components that I speak to my patients a lot about, especially lately, is the mental health and stress, right? So we know the fact that the last 3 years for every single one of us has been incredibly stressful in one way or another, right? But I don't think the fact that, it's always been kind of like almost like a voodoo to talk about patients' mental health and how it affects and everything else. Mental health is directly linked to your physical health. Stress is directly linked to your physical health. There's a reason why there was actually in the 80s a diagnosis of broken heart syndrome. It falls under the category of what's called stress-induced cardiomyopathy, and that is when there's some sort of a huge emotional stressor that takes place, and it happens mostly in women, that a surge of catecholamines or hormones that are being released that significantly affect your heart muscle and create a significant weakness in your heart muscle, mimicking almost as if you're having a heart attack, but you don't have any significant blockages. So stress really does play a significant role. So, it's hard. It's really hard to know what is the best way for every single patient to sort of monitor their stress levels and their mental health. But I think that there are certain simple steps that people can take. And, Jeanine, if you want, I can possibly go through a couple of them.
Please do.
Okay. So this is what I usually recommend for some of my patients. And that is to make a to-do list, right? Prioritize and delegate items. And one of the most important things is that on that to-do list is you time, right? And, I grew up in the culture, very old school immigrant culture, that anytime that you take you time, you consider to be selfish, right?
Mm-hmm. That's true.
Because, right?
That's so true.
And that's not the case, because I can tell you this much, that if there is no you time, if you don't take a little time for yourself, you will be completely and utterly useless for anyone around you, whether or not it's your children, your spouse, your parents, your loved ones, your friends. You're just not going to be efficient enough to be there for them. So taking that you time is not being selfish, no matter what your grandmother tells you.
Right.
It's important to have a positive attitude. And listen, I get it. It's way easier said than done. But I think that with all of the travesties that are happening in the world at this period of time, we have to be able to find a little bit of that positivity. And whatever it is that you need to do to start your day in that manner, do it. Whether or not it's a morning brisk walk, whether or not it's blasting music in the shower, whatever it is, give yourself that ability to just genuinely smile. And genuine, I mean genuinely smile to the point where your eyes are smiling, not just the corners of your mouth. Sleep. Yes. Sleep is really, really, really important. Trying to get 7 to 8 hours of sleep is important. But it's not only the quantity of sleep, it's the quality of sleep. Because I have so many patients of mine that come to me and say, you know what, doctor, I know what you're going to tell me. I know you're going to tell me the fact that I have to sleep 7 to 8 hours. And I do, but I wake up so tired and so exhausted. I need to nap during the daytime. And that's a trigger for me to understand what's the quality of their sleep. And a lot of patients do suffer from obstructive sleep apnea, which is another significant risk factor for underlying heart disease, right? So, and one of the other things that I actually suggest to my patients is enjoy the time with your loved ones around you, right? But I take care of a lot of busy people, a lot of busy women, actually. Yeah. And they look at me and they're like, you know what, Evelina, I'm busy. I don't know when you want me to do this. Yeah. Give me something that I can do, something that's tangible. So what I tell them is this. First and foremost, pack a healthy snack, just so that you don't grab a cookie or a brownie that is left behind somewhere in the office, okay? One of the things that I always recommend for my patients also is to do what's called walk and talk meetings, right? A lot of my patients are, within the administrative world, leadership world, they're in a lot of meetings. I'm like, okay, put on your headphones and walk and talk. I do that sometimes because I've had to do a lot of meetings lately. And I literally find it that when I do that, it increases my energy, it relieves a little bit of my stress. And interestingly enough, I actually think the fact that I come up with better ideas when I'm actually walking and talking.
That is so true. This is just all so much information. Where can someone find out more information about you and Northwell Health?
It is actually very easy. You can actually look me up at Evelina Grayver, MD. You can also find information on me through the American Heart Association page as well. I took over as the president for the Long Island Board of Directors for the American Heart Association.
Wow. Thank you so much for being here, Dr. Evelina Grayver, the Director of Women's Heart Health at the Katz Institute for Women at Northwell Health and Assistant Professor in the Department of Cardiology at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. We hope you stay safe and continue to stay healthy, and thank you so much for sharing this important health information.
Thank you so much for having me on this show. It's been a pleasure.
This is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College, and we want to thank you for listening to this week's edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to whpc@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the Nursing Department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.